Good afternoon, and welcome to our series of webinars focused on bringing you information about COVID-19, infection control, and other nursing home-related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who is interested to attend. My name is Kathy Caudill. I'm a communications specialist with Quality Insights. Today's webinar topic is depression in post-acute and long-term care. Everyone has entered the meeting on mute, but we will have a Q&A following the presentation. If you have questions or comments, please submit them using either the chat or the Q&A tool in your Zoom menu. We invite you to join us every Wednesday for more of our weekly webinars. Next week's topic is person-centered care's influence in long-term care facilities. If you're interested in joining, that will be the same time and place next Wednesday at 2 p.m. And now I'd like to introduce our guest today, Dr. Abhilash Desai. Abhilash Desai is a board-certified geriatric psychiatrist, medical director of Idaho Memory and Aging Center, and clinical associate professor in the Department of Psychiatry and Behavioral Sciences at University of Washington School of Medicine, Idaho Track. He is the co-author of the book Psychiatric Consultation and Long-Term Care, A Guide for Healthcare Professionals, second edition, published in 2017. His practice focuses on helping individuals living in post-acute and long-term care facilities, older individuals with dementia, and other mental health challenges, and their family members live their best life possible in all care settings: home, long-term care, hospital, and hospice. He has been in practice for 24 years. Dr. Desai, thank you for joining us today.
Thank you, Kathy. Delighted to be here. So as Kathy mentioned, we'll focus on depression in post-acute and long-term care. Next slide. Few disclosures. As Kathy mentioned, I get royalties from the book I wrote with Dr. George Grossberg, who's a nationally and internationally renowned geriatric psychiatrist at St. Louis University, where I did my fellowship. I also have written a book with my wife. She's a psychologist, Dr. Faith Kalyana Desai, One Day Mindfulness Millionaire. Mindfulness is one of the standard recommendations in wellness in all areas, including depression. And I do not intend to discuss any off-label investigative use of any commercial products or devices. I have no relationships to any big pharma. Next slide. So the three objectives for today, one is to discuss prevention of depression in post-acute and long-term care populations. So assisted living communities, nursing homes, and many other long-term care populations like PACE, or all-inclusive care of the elderly. Then also we'll talk about suicide prevention, and we'll discuss non-pharmacological and pharmacological interventions that are evidence-based to manage depression. Next slide. So I know we routinely do PHQ-9 when we get a resident, especially in post-acute and long-term care institutions. And if they have subsyndromal depression, say their PHQ score is between 5 and 10, so obviously 0 is the ideal. Or if they have a past history of depression, they are on antidepressants, and currently they have just some symptoms, then this will be an excellent population to proactively talk about, hey, we can help you prevent your depression from getting worse. Are you interested? We can educate them, talk about behavior activation. It's an evidence-based intervention for depression treatment. One of the handouts that will be dropped in the chat is overcoming depression, anxiety, and anger, various non-drug interventions. So in that, you'll have the full description of behavior activation. Also, there is a lot of research to show that exercise can improve depression. And in cases of mild depression, it could be as good as an antidepressant. Many times we need family interventions. Obviously, individual counseling, psychotherapy would be an excellent intervention to start off with if the person who has just been admitted is struggling with depression. Next slide. Even if you get a 0 or a very low score on PHQ-9, I would urge you to inquire if they have been experiencing a lot of loneliness and social isolation, especially if they don't have an excellent support system in terms of friends and family. Then engaging them in various activities in the nursing home, such as reminiscence groups, group physical exercise programs. If they have family members in different parts that they can't visit in person, then video conferencing with them. Again, various specialized support groups, even volunteering in the nursing home, even doing some teaching if they have some skills and interest in teaching other residents and even staff in any areas that they have expertise in, doing book clubs. All these interventions can go a long way in prevention. If you see this reference, Canadian guidelines, those are one of the best guidelines to follow in terms of prevention, assessment, and treatment of depression in older adults. And all of that would apply to long-term care populations. Next slide. Another way to approach prevention is step care approach. So let's say that you have somebody with depression, they agree for treatment, but they don't want formal treatment like medications or individual counseling, and their depression is mild. Then all this DIY strategies we talked about, exercise, gratitude-based interventions that's in that document, bright light therapy, which is also in the document, behavioral activation. There is mention of supplements like omega-3. If all these things can be started, and there is a good chance that a lot of people will have resolution of depression, their scores will come down, and they feel happy and engaged in life. And then you can do just watchful waiting to see if all these things work. Many a times, the stress of just being admitted to a facility resolves. They realize that things are much better in many ways, and all their sort of catastrophizing about being in a long-term care facility is not true. A lot of staff are very supportive and nice. The other residents are nice. They have great activities. Then just watchful waiting might take care of the problems. And if their depression gets worse, then you say, all right, it's time to do individual counseling. They agree. If the depression gets more worse, then say, hey, let's add an antidepressant. They agree. So that's what stepped care approach means. Next slide. So again, the key thing for all of us to do at every level is to instill hope and positive thinking. And again, to me, positive thinking is a skill. What does that mean? It's like swimming. So the more we do it, the better we'll get at it. But sometimes we might need a coach to know what's the best way to swim, what's the best way to learn about positive thinking, learn about learned optimism. Sometimes we are being too pessimistic, and we have another virus that we get infected, doom and gloom virus, I call it. So again, we can do a lot of this work of instilling hope and positive thinking to prevent major depression in long-term care facilities. Next slide. I'll switch gears to talk about suicide prevention. So that was the second objective. So again, in my 25 years now in long-term care, death by suicide is rare. But suicidal ideations I encounter once a week, in fact, and it's very prevalent. There's some research that this is going up in terms of number of people voicing suicidal thoughts. It could be passive, I wish I was just dead, or more active plans that I'm having thoughts that I should take my own life. Next slide. So what I recommend to my staff is to, number one, do a Columbia Suicide Severity Rating Scale, and then do a Stanley Brown Safety Plan. Both the links to these documents will be dropped in the chat. They are freely available. Believe it or not, even police officers now are trained in Columbia Suicide Severity Rating Scale when they encounter somebody who has called them in the community, on the street, asking for help because they are having intense thoughts that they want to end their life. Next slide. So let me just share a couple of cases to highlight what do I mean. So I have one case last week where I received an email from a social worker from a nursing home that this resident who's 81 years old with Parkinson's disease just got admitted, and they were upset and angry and did not realize that they might be in the nursing home for post-acute skilled rehab for much more time than they thought they would be. They were there 6 months ago. And in anger, he said that, I wish I was dead, I'm done with this. The staff had been trained by me to do Columbia Suicide Severity Rating Scale. When they did the scale, it comes up as, yellow, orange, and red. So yellow is when only one or two items are marked yes. For example, have you wished you were dead or wished you would go to sleep and not wake up? So he would score a yes. Have you actually had thoughts of killing yourself? He said no. And then you don't have to do anything further than that. But if, let's say, he had said yes, then the staff would have gone on to ask questions 3, 4, and 5, and 6. Have you been thinking about how you might do this? Let's say he said yes. Have you had thoughts and some intention of acting on them? Let's say he says yes, I'm thinking of using a gun. Have you started to work out or worked out details of how to kill yourself? Do you intend to carry this plan out? Again, he would say, no, I'm just struggling with these thoughts. Have you ever done something, started to do anything, or prepared to do anything to end your life? You would say, 6 months ago, I had this and I was starting to write a suicide note. So these are the questions, and these are the answers elicited would change how we intervene. For this specific person, as I said, he had this thought in anger. And then when the social worker did the suicide scale, he scored just a yellow. And then the social worker spoke, and he did say that, no, he was upset. He did not mean it. There is a lot to look forward to. His family is coming to visit him within a month. Unfortunately, they are not in the same town. They're in another state, in fact. And then they'll be bringing the 3-month-old grandbaby. He has not seen the grandbaby. He's looking forward to it. He reports no plan to hurt himself, reports that he was just very upset when he made negative statements. The social worker asked him if he would like to talk to me, a geriatric psychiatrist. He says, no, there is no need. Social worker asked if she could arrange for individual counseling. He said yes, and the resident appeared distressed and relaxed and in no distress by the end of the interview. So that's one case. The second case is, again, I get an email. Good morning, Dr. Desai. One of the providers saw a resident who had stroke, and she was expressing them depressive symptoms. So the provider asked that you get involved. This is a social worker who emailed me, have visited her. She's currently working to accept recent health status changes. This is concerning her that she's recently lost 2 brothers suddenly to heart conditions. She has great support from her significant other. He's in the facility daily to spend time with her and support her in the process. The recent PHQ-9 score reported only mild depression. Her score was 8. Do you have any recommendations? So I reviewed her electronic medical records. She's on omeprazole. So I mentioned, so what I do is have a biopsychosocial spiritual approach. So even though it looks like a lot of these are psychological factors, I look into any biological factors that might add to the problem. So in her case, omeprazole and proton pump inhibitors can lower vitamin B12 and magnesium. Vitamin D deficiency is very common. Dehydration is very common. So I suggested we check those levels. She was on thyroid medicine. It'll be good to make sure that her TSH is within normal range. I told her I agree with her that let's avoid any antidepressants, and we can help her with non-drug interventions such as gratitude-based interventions. She has that document, Overcoming Depression, which has various other non-drug interventions. I also suggested to talk to her if she's interested in post-stroke support groups. So these are clinical examples of how we can help without actually going to the antidepressant stage. Next slide. So a little bit more about geriatric depression, since most of the long-term care population are above the age of 65. And many a times they may not say that. If you ask them, are you depressed or sad? They would say no, but they might endorse that they have lack of emotions. They just don't feel anything. They feel blah. Many a times the depression manifests, especially in men, as irritability and anger, and many a times anxiety and somatic symptoms rather than feeling down and depressed. The classic triad that I'm bad, the future is bad, the past is bad. You may not see those typical symptoms of depression we see in younger population. Next slide. And again, I mentioned PHQ-9, which is our standard scale, but sometimes I do geriatric depression scale. I think sometimes that catches depression that is not caught by patient health questionnaire. And then if they have advanced dementia, if their cognitive impairment is such that they cannot reliably answer the PHQ-9 questions, then I would suggest the staff do a Cornell scale for depression and dementia. It's freely available in the internet, and it's a behavioral scale. So you would look for behavioral signs of depression. They are tearful, they look sad, they are not having a lot of physical activity, they are not engaging in activities that they previously enjoyed, and you know them well and know that these are the activities they enjoy. They're not enjoying seeing their grandchild anymore. So you would then score positive on these observational scales. Next slide. So again, even if they score positive, that doesn't mean that they have, quote, clinical depression, end of quote, or quote, major depression, end of quote. You can score high on PHQ-9 and also have a medical cause of depression. I've had patients where they have had hypothyroidism. When we treated that, the depression cleared up. There was no need for counseling and no need for psychiatric medications, antidepressants. Most of the time, when we do a workup, we find things that are comorbid and we need to address them. So maybe they have B12 deficiency, vitamin D deficiency, D for David. They have ongoing pain along with major depression. So it's important to address all these comorbid issues. So that's important during the initial assessment by the primary care providers. I also review medications lists routinely because there are many medicines that can cause depression. And then it's important to educate the person, the resident, as well as the staff. I've seen steroid-induced depression. I've seen interferon-induced depression. I've seen overcorrection of thyroid-induced depression. So in these cases, deprescribing, rational deprescribing would be the appropriate intervention. Obviously, not always you can discontinue the medication, such as steroids, but then the knowledge is important because that will guide treatment. And then substance-induced depression, you'll be surprised how common now substance use disorder is becoming in long-term care. And alcohol use, cannabis use, you may not even be aware that they are doing it sometimes, or that you might say that it's occasional, but they're using it much more. So again, it's important to inquire about these. Next slide. So these are the workups. Sometimes I also do magnesium, folate levels, and C-reactive protein to see if there is non-specific inflammation. CBC sometimes is useful for severe anemia. Again, we have many medicines that can cause these problems. So also to look for medication-induced abnormalities in these tests. Next slide. Psychotic depression is quite common in the elderly and even in long-term care. So it's important to not only stop when you ask for depression, but to look for specific psychotic symptoms, delusions, distressing delusions. They are convinced that they have done something terrible in the past and they are being punished for that. Hallucinations where they're hearing voices telling them that they should take their own life. So please inquire, because the treatment is different. We may have to add an antipsychotic to an antidepressant, or they might have to even be referred for acute inpatient psychiatric treatment. Next slide. These are some of the clinical tips. In my work, many a times the staff feel that they want to help, but they don't realize that what they think is clinical depression, I think is just normal human reaction to incredible amount of stress and change in one's life circumstances. So it's important not to medicalize human suffering. Many a time they are just adjusting to all these changes. So they have significant depression, but it's not major depression. So we should avoid any antidepressants. Maybe individual counseling might be the way to go besides all these non-drug, do-it-yourself interventions. Again, grief and prolonged grief disorders are common and often misdiagnosed as major depression. And again, treatment would be primarily psychosocial, spiritual interventions. Bipolar depression is often misdiagnosed as unipolar major depression. So again, it's important for all patients where we diagnose major depression to screen for past episodes of hypomania, mania, and current mixed symptoms that could indicate a bipolar depression, because the treatment is very different. If you give antidepressants like SSRIs, you might actually induce mania and rapid cycling and destabilize bipolar disorder. And antidepressants do not improve depression in bipolar disorder. And again, depression can be a part of PTSD. So again, please screen for trauma. We all need to move towards trauma-informed care. And then the treatment is very different. Next slide. So I do collaborative geriatric psychiatric care via telemedicine. I work closely with primary care providers. Please consider that approach. Next slide. You know, we again don't realize that for mild major depression, you don't have to give antidepressants. Education and psychotherapy might be enough. Next slide. This is the list of non-pharmacological interventions that I talked about. Lifestyle medicine-based interventions like exercise, nutrition, especially Mediterranean diet, would be also important to discuss. Next slide. Again, when it comes to psychotherapy, cognitive behavior therapy has the best evidence. When you see that you add an antidepressant and patient is responding only partially, that's another time to talk to them. Hey, counseling really works. Let's give that a shot. Next slide. Many times, patients are struggling through despair, hopelessness, say they have cancer, and they find that the life remaining is not meaningful. Then in that case, meaning-centered psychotherapy would be more important than cognitive behavior therapy or other forms of psychotherapy. Next slide. Again, a lot of our patients have seasonal affective disorder, but now there is research that even non-seasonal depression can benefit from bright light therapy. So it's a good adjunct to other interventions. Next slide. Again, a lot of our residents, patients would be interested in complementary and alternative therapies. So we should talk about it and then maybe add to more traditional treatments like individual counseling. Next slide. I don't recommend pharmacogenomic testing. As I said, I follow these Canadian guidelines, but occasionally I have done it. It's rare. But now I have a lot of patients who themselves get it done, and then I have to use that data, and I generally involve our pharmacists in interpretation. Next slide. So you might get a data that they have specific findings, like they have certain liver enzymes that are working excessively, and then we might have to avoid certain antidepressants. So I think it's important to take that into account when such testing has been done, but I would not recommend doing it proactively. Next slide. Again, we need to realize that although lithium is very good for many patients with depression, it's better to avoid that in many nursing home patients. We have to realize that if they have kidney disease, we may have to use lower dosages, such as duloxetine. Maybe 30 milligrams might be enough. We don't have to use 60 milligrams. Next slide. Again, I follow Canadian guidelines. So my go-to drugs are either sertraline or duloxetine. If they have chronic pain, I go for duloxetine. If they have severe comorbid anxiety disorders, and then I go to sertraline. But there are other options too. It's best to avoid fluoxetine and paroxetine. Next slide. And again, partial response is common. Then sometimes you can just wait, add psychotherapy. You may have to add another antidepressant, such as mirtazapine, say, to sertraline, or maybe aripiprazole. Aripiprazole is an antipsychotic approved by the FDA for treatment-resistant major depression and has good data in the elderly. Next slide. We don't realize that even SSRIs are not benign. You can have low sodium, falls, increased bleeding risk, so we need to monitor that. Next slide. We need to be careful that when we are discontinuing antidepressants because they did not have any positive effects, or that now they don't need it, they have been stable for a long time, we have to do it very slowly, otherwise you'll develop antidepressant discontinuation syndrome that is described here. Next slide. These are some of the resources that I recommend. Next slide. Again, mindfulness is a good adjunct to all interventions. Next slide. These are the websites, and there could be online support groups worth offering them to our patients, residents. Next slide. These are the free, high-quality apps that I would recommend for relaxation exercises. Anxiety is very common, but even if it's just depression, these relaxation and meditation exercises will be very helpful. Next slide. And again, more apps if they have comorbid insomnia or trauma. Next slide. That's it. Let me stop here. Happy to take questions. Hope this is useful. Namaste. Thank you.
All right, thank you, Dr. Desai. If anyone has any questions, please submit them using either the chat or the Q&A tool in your Zoom menu, or you could raise your hand if you would like to ask your question out loud. And while we're waiting, I'd like to, again, invite everybody to next week's webinar, which is on person-centered care's influence in long-term care facilities. That will be the same time and place next Wednesday at 2 p.m. We also invite you to bring your questions to our virtual live chats every Tuesday and Thursday at noon. One of our quality improvement specialists will be there to answer your questions on topics such as quality improvement initiatives, infection control, or MDS coding. You can find the links to our live chats and webinars in the newsletter that we send out every Friday called the Last Minute Lowdown. And if you'd like to receive that newsletter but don't think you're on the mailing list yet, you can email me at ccaudell@qualityinsights.org and I will get you on that list. And now I will look to see if we have any questions. It doesn't look like we do so far. I just put my email in the chat, and for those of you who are keeping an eye on the chat, I've been dropping in those resources that Dr. Desai has mentioned. And I will also be emailing everybody later this week the link to the recording and the presentation slides, and I will include the links to these resources as well. And actually, I do have the link to the slides. I'll go ahead and put that in the chat as well. Now that is there.
The two key messages are instill hope and positive thinking.
Thank you. And someone else just wrote in the chat, thank you so much for your time. This is great information. Does
Welcome.
anybody else have a question? I think that might be it. Dr. Desai, was there anything else you wanted to add before we wrap up for today?
No, I think we can do a lot to help prevent, accurately diagnose, and treat depression in long-term care. That's it. Thank you.
Thank you. All right, then I will go ahead and wrap us up. Before we sign off, we'd like to ask everybody here to answer a short evaluation of today's webinar. It is anonymous and it will show as a pop-up as soon as the webinar ends. So if you have a couple minutes to fill that out, we would appreciate it. Dr. Desai, I'd like to thank you for joining us today and for this great presentation. And I'd like to thank everybody here for joining us today, and we hope to see you back here again soon.
Thank you, everyone.
Thank you.